Okay, 3 o'clock already. Okay. Ladies and gentlemen, dear my colleagues in Taipei, I think it's very my great honor to invite Professor Bernardo from Bordeaux University, France, to give us a special lecture today. I think maybe some of you may know that Professor Bernardo is a well-known researchers on the deep brain stimulation for many years, and now currently he is also the president of Deep Brain Stimulation Society. So I am very happy to meet him in 2023. It's the first Congress of the Deep Brain Stimulation Society. So, and he is also very kind of me to he can share his knowledge about the deep brain stimulation, the progress and the past and the future in our class. So let's welcome Professor Bernardo.
Thank you very much. Thank you. It was really a pleasure to have you with us in the first meeting of the DBS Society in Grenoble. And I'm really very happy to be here with you today to give this talk. And as I told you, I love to share my knowledge with students and with colleagues. Thank you so much for the invitation. I'm really very happy to be here with you. I just start sharing my screen. Is it okay? You see my screen?
Yes.
The first slide. Okay. And my task today is to talk about the involvement of basal ganglia in the pathophysiology of Parkinson's disease. And it will be really from bench to bedside, and then from bedside to bench to try to understand what happened with deep brain stimulation. Um, the first thing I want to say is that deep brain stimulation is a kind of approach that was developed by the implantation of the electrodes in a deep area of the brain. Here is the case of the subthalamic nucleus, and you can see the two electrodes implanted in the subthalamic nucleus. Then when we implant correctly these electrodes in the subthalamic nucleus, we can connect them with a pacemaker, a battery that we can have here, IPG, that will be connected with the two electrodes that they are here. This is the real size of the stimulator, but now we have a thinner and smaller stimulator, which is rechargeable. And this one, it was an old one with a duration of life of 5 to 7 years. Now we can have the guarantee with the rechargeable stimulator for 15 years with Medtronic and 25 years with the stimulator from Boston. And then if you look to this MRI, you can see the superimposition of the two electrodes implanted perfectly in the subthalamic nucleus. As this brain is really symmetrical, you can see like if we are implanting only one electrode. In this patient, we have really a very good symmetry between the two subthalamic nucleus in his brain. And here you can see the contacts of the stimulation. For this kind of electrode, we have 4 contacts, but now with the multidirectional electrodes, we can have more than 4 because of, for the deeper one, we have 1 contact. In this one, we have 1 contact, but with these 2 electrodes, we can have 3 contacts for each one. And this can help avoid side effects for some patients. And the first application of deep brain stimulation was done for Parkinson's disease. And this application was done due or thanks to animal model of Parkinson's disease, because we tried in these animal models to understand the pathophysiology of Parkinson's disease, especially for basal ganglia involvement. And then this approach was also transmitted and applied for other pathologies like dystonia, like OCD, obsessive compulsive disorders. Now many tests are done for depression and also anorexia and obesity in the United States. And here I will limit my talk to Parkinson's disease, and we know, or the neurologist knows now that this pathology was described for the first time by James Parkinson, who described the pathology as shaken palsy pathology. Shaking is because of the tremor of the patients, and palsy is the paralysis of the patients with akinesia, severe akinesia. And he described in his book all the symptoms that we know in Parkinson's disease, even the non-motor symptoms, everything he described it. Even pain, for example, we know that pain is one of the non-motor symptoms, and James Parkinson already described it in his book in 1817. It's a very, very nice book to read and to for the description of the disease. And we know that this pathology is characterized by the triad of the motor symptoms, akinesia, rigidity, and the wrist tremor, but not only, because the pathology is also known with non-motor symptoms like depression, pain, emotional problems, um, anxiety, and other non-motor symptoms. And this is also a neurodegenerative disease. These symptoms are due to degeneration of dopamine neurons in the mesencephalon. You can see here the location of the mesencephalon if you cut the brain at this level. And here you can see the normal subject. We can see tyrosine hydroxylase positive dopamine neurons. We can see them there here. But in Parkinsonian patients, we have the absence of these dopaminergic neurons that can reach in the advanced stage of the disease 90 to 90% loss of dopamine neurons. And if we look to the striatum, and we can see that we have also a progressive decrease in the level of dopamine in the brain. And it's really done very, very progressively with time. And we know now that the symptoms doesn't appear in the beginning of the degeneration of the neurons. We need to have more than 50 to 60% of dopamine depletion to see the development and the manifestation of the motor symptoms. And the first idea, as Parkinson's disease is a dopamine, first is a dopamine pathology, the first idea was to give dopamine to the patients. But the problem of dopamine is that it doesn't cross the brain, blood-brain barrier. This is why it was impossible to give dopamine to the patients. And if we look to the synthesis of dopamine, dopamine is synthesized from tyrosine as a monoamine, which is transformed to dopa by tyrosine hydroxylase. Then L-dopa is converted to dopamine by the aromatic amino acid decarboxylase. And the idea was to don't use dopamine because it's not crossing the blood-brain barrier, but use L-dopa. And L-dopa, when it reaches the brain, it will be converted to dopamine, then released in the synaptic place, and it can be fixed on two families of receptors, D1 receptors family, which is composed by D1 and D5, and also we have the D2 family with this D2, D3, and D4 receptors. And if dopamine is fixed on the D1 family, it will play an excitatory role. But if it's fixed to the D2 family receptors, it will play an inhibitory role to inhibit the cell bodies. And the first idea of the use of L-dopa was proposed by Arvid Carlsson, who is a Swedish doctor and got the Nobel Prize in 2000 for all his work on dopamine. He was working on his life on dopamine, and he proposed He was the first to propose L-DOPA as a treatment of Parkinson's disease. And this was really a revolution in the therapy of Parkinson's disease. And the first work that he did was on the rabbits. It was a special model of Parkinson's disease, which was not focusing on only dopamine depletion, but Arvid used this reserpinized rabbits. He injected reserpine, and reserpine is an inhibitory molecule or drug which will inhibit the synthesis and the release of dopamine. And you can see that by injecting reserpine in the rabbits, they are totally akinetic, similar to the advanced stage of Parkinson's disease. And when he gave them L-DOPA, you can see that they are running. It's because of L-DOPA, which is improving the state and replacing dopamine inside the brain and playing its controlled role on motricity. This is why he showed that he improved his akinetic rabbit by L-DOPA and they became totally normal. And this was the time that Arvid Carlson proposed L-DOPA to to practitioners, and it was used first at the end of the 60s for Parkinsonian patients. And we know that L-DOPA is very, very efficient in the beginning of the disease, especially during 4 to 5 years in the beginning of the manifestation of the symptoms. It is really efficient on akinesia, rigidity, rest tremor, and also on some non-motor symptoms. But this is limited in time. It's really very, very good therapy, but very limited in time. This is why with long-term treatment of L-DOPA, we have a lot of complications, such as the fluctuation of the therapeutic effect. The patients can be good at time, but they switch to the off situation very, very quickly, and this can fluctuate on all the day. And it's really a problem for the patients. And the second complication is the manifestation of dyskinesia. Dyskinesia are these abnormal involuntary movements that the patients cannot control. They can start dancing involuntary during the day after taking L-DOPA. But now we don't start the therapy of Parkinson's disease with L-DOPA from the beginning of the manifestation of the symptoms. And now the neurologists are giving dopamine agonist to delay these complications of L-DOPA. And L-DOPA is used 3 to 4 years after the beginning of the disease, and the patients can benefit from the treatment with dopamine agonist. Then we add to this agonist, we add L-DOPA when the dopamine agonists are not working perfectly. And this is really the situation actually. And facing the limits of L-DOPA therapy, and we need to search new therapeutic approaches. But as you know, to propose a therapeutic approach, we have to understand the pathophysiology of the disease. And for that, we need the development of animal models of disease, which is here the case of animal models of Parkinson's disease. And we have really a big chance. All people who are working on Parkinson's disease have this chance with a lot of animal models that we can use. I put here only the three major, most used animal models, which are the mice, the rodent, the rats, and also the non-human primate. And in our lab, we have all these models because we start working in the beginning on mice and rats. And when we have some promising results, we can switch in our lab to the monkeys. And this was done also for deep brain stimulation development, because everything started in the animal models before we proposed to use it in Parkinsonian patients. And from these animal models, lot of studies in the world were done by many teams to try to understand the networks and also the functional organization of the basal ganglia and the motor circuits. We can see here the cortex, with the projections to the basal ganglia. Then the basal ganglia are projecting to the thalamus, then the thalamus to the cortex. And this is really, I will talk in details about this network because it's very important, and he was really used to understand the pathophysiology of Parkinson's disease. And from these animal models, we can have the first simple model by the injection of 6-hydroxydopamine, which is a neurotoxin specific to dopamine neurons. We can see that we can inject it in the medial forebrain bundle. Here we have all the tract projecting from the substantia nigra compacta to the striatum. If you inject the 6-hydroxydopamine in the medial forebrain bundle, the MFB, you will have a very severe loss of dopamine in the brain. And we can also inject it in the substantia nigra compacta. And to use a partial model of the disease, we can inject it also directly to the striatum. But in our case, we are working on the advanced stage of Parkinson's disease. This is why we prefer to inject it in the medial forebrain bundle here to reach all the axons and the fibers projecting from the substantia nigra to the striatum. And here at the end of the experiment, we need to do a control of dopamine depletion. And we can see here the anterior, intermediate, and the posterior part of the substantia nigra compacta. You can see that the injection was done on only one side. This is why we can see the degeneration of dopamine neuron, severe degeneration in only one side here. That reach 90% of the degeneration of dopamine neurons. And here you have the normal side. And we have the same in the intermediate part and also in the posterior part. And here in the striatum, as the substantia nigra is projecting to the striatum, we can see also a total depletion of dopamine in the anterior, intermediate, and also the posterior part of the striatum. This is really typical with this model in rodents for the rats and also for mice. For the MPTP monkeys, the MPTP is also a neurotoxin which is specific to dopamine neurons, but we can obtain this model with severe Parkinson's disease similar to the advanced stage of Parkinson's disease in the patients by repeated injections of MPTP intramuscularly or intravenously. And we can see here when we repeated the injections of MPTP 15 or 14 days after the onset of the injection, we start to have the manifestation of the symptoms, which will be stable around 20 days after the beginning of the injection. Then we can have this stable model with time. And if we look to the substantia nigra compacta, here we have two staining. We have the tyrosine hydroxylase immunostaining in red and the Nissl staining for the other population of neurons in the substantia nigra in blue. And if we look to the evolution after the beginning of the injection of MPTP, we can see that we have a progressive degeneration of dopamine neurons, here the red neurons. And we can see all the time some resistant neurons. We never have 100% of the degeneration of dopamine neurons. We have around 80 to 90, 95 maximum percent of the degeneration of neurons. And if we look here to the caudate and the putamen, you can see also this progressive degeneration of the fibers. And here you can see with the advanced stage, we have very severe degeneration of the fibers, dopaminergic fibers in the striatum. And these models, rodents models, and also non-human primate, were really very, very useful in understanding the motor circuit in the normal and the pathological situation. Now, if we look to the physiological situation, this is a network which is working really very good. And we can see the involvement of the basal ganglia here. They are located at this level of the brain. We can see that the basal ganglia are receiving first the projections from the motor cortex, Then the motor cortex, when he projects the information to the basal ganglia, the informations will be treated and finalized in the basal ganglia. Then from the basal ganglia, the information is going to the thalamus. Then when the thalamus treats the information, he sends it to the cortex, and then the cortex can order the execution of a movement through the spinal cord. And this is in general the configuration of the motor circuit. And when you want to execute a movement, the first step is that the cortex order the execution of the movements by informing the basal ganglia to have this precise movement that can be executed by the person. And if we go now more in detail, we know that in the basal ganglia, which are here, the striatum is the principal input structure receiving afferent information from the cortex. The information when you want to do a movement, the information is coming from the cortex to the striatum first. And this is why we say that the striatum is the principal input structure of the basal ganglia, receiving the information from the cortex. Then the striatum will send the information to the output structures of the basal ganglia, which are represented here by the internal part of the globus pallidus and the pars reticulata of the substantia nigra. And these output structures of the basal ganglia will transmit the information outside the system to the thalamus, which is here. Then the thalamus will send the information to the cortex, which will order the execution of the movement. And this circuit was modeled in the beginning of the 90s by especially the team of Malon DeLong in Atlanta. And they proposed this anatomofunctional organization of the basal ganglia inside the motor circuits. When you look to this model, you can say that it's really very, very complicated. But today I will try to explain it to be a very simple configuration of the motor circuit, and you will see that it's really not complicated. You have just to start with the information coming first from the cortex. You see here the cortex, the different area of the cortex involved in the motor circuit. We have the supplementary motor area, the premotor cortex, and the primary motor cortex. And here you have all the basal ganglia structures. We have here the thalamus and the PPN, which is not very, very important at this stage. I will not insist on the PPN, but we have just to look to the cortex, the basal ganglia here, and the thalamus. And when somebody wants to do a movement, a precise movement, the information comes first from the motor cortex or the supplementary motor area. Okay, and this information coming from the cortex go directly to the caudate and the putamen of the striatum. And when the information is arriving to this input structure of the basal ganglia, it has to reach the output structures of the basal ganglia via two pathways. We have here the direct pathway projecting directly from the striatum to the output structure of the basal ganglia. This is why we say that it's a direct pathway, because of this direct projection, monosynaptic projection from the striatum to the output structures. And we have this indirect pathway because it will go through different structures, especially the globus pallidus externus, the subthalamic nucleus, and the final information will go from the STN, the subthalamic nucleus, to the output structure of the basal ganglia. These are the two principal projection going with the information from the input structure, which is the striatum, to the output structure of the basal ganglia, represented here by the globus pallidus internus and the substantia nigra reticulata. And this information, when arriving to the output structure of the basal ganglia, it will be treated and finalized here and projected to the thalamus. The information is going from the output structures to the thalamus. Then the thalamus will send the information to the cortex, and the cortex will inform and send the final information to the brainstem and to the spinal cord for the execution of the movements. And there is another pathway which was discovered later, which is the hyperdirect pathway coming from the cortex to the subthalamic nucleus, which is excitatory. Here, everything excitatory is in red, but the black color is the GABAergic inhibitory projections. And we can see here that the only structure of the basal ganglia, which is glutamatergic excitatory, is the subthalamic nucleus. This is the only excitatory structure using glutamate as neurotransmitter. And these informations from inside the motor circuits is controlled by the dopaminergic neurons coming from the substantia nigra compacta to the striatum. This is why we say that dopamine is a modulatory neurotransmitter, because dopamine will modulate the information coming from the cortex. When the information is coming from the cortex, dopamine will try to modulate this information by playing on D1 and D2 families of receptors. D1 receptors are located on the direct pathway, the neurons, projecting striatum neurons of the direct pathway. And it means that the dopamine will play an excitatory role on the neurons projecting from the striatum to the output structure of the basal ganglia. And for D2 receptors, they are located on the cells who are projecting to the globus pallidus externus. And this is really very, very important, because without dopamine, we will have no modulation of the informations coming from the cortex, and it will cause problem. And the problem is the pathophysiology of Parkinson's disease. When we are missing dopamine neurons in the substantia nigra, we have no more modulation of the information inside the striatum. This is why we have this problem of the disorganization of the neuronal activity in all the networks, in all the structures of the basal ganglia. And this is what we will see here with in the globus pallidus externus, which is located here. We can see that in the normal situation, you have a tonic activity, as you can see here. We have a kind of regular to slightly irregular action potential. Every line is action potential spikes recorded in the globus pallidus externus. And by giving the MPTP to the monkeys, we can see that this tonic activity will be transformed to irregular and also bursty activity in the GPE. The bursts are this accumulation of spikes that we can see in all these recordings. This is during the stage 1, and this is in the stage 2 of the pathology. And we can see that here, what is important is to see this switch from the tonic activity in the normal situation to the bursty activity after the degeneration of dopamine neurons. And it's exactly the same case for GPI, for the internal output structure of the basal ganglia, which is the internal globus pallidus. In the normal situation, we have a high level of the firing rate with a tonic, regular to slightly irregular information, spikes. And when we give the MPTP to the monkeys, you can see here this bursty activity, which is really typical to the pathology after the injection of MPTP. It means after giving the pathology, Parkinson's disease, to the non-human primates in the monkeys. And we can see here also this bursty activity. Now, another example with action potentials here, the spikes recorded in the globus pallidus internus. Here is the normal situation. We have a firing rate around 60 spikes per second with tonic activity. And we can see here in Parkinsonian situation, in monkeys, after injecting MPTP, we have this bursty activity with oscillations. We can see really in these 3 examples of cells that we have these oscillations with burst who replaced the tonic activity of the normal situation. Now, another example of the subthalamic nucleus. It was a publication from the team of Hage Bergman and Malon DeLong, and they recorded the neuronal activity in the subthalamic nucleus in the normal and also in MPTP monkeys. And that we can see here, the normal are the white bars, and here we have the black bars for MPTP monkeys. And we can see that the firing rate is increased here, the discharge rate, the firing rate. You can see that we have more cells with this high firing rates in MPTP monkeys, and for the normal monkeys, the higher firing rate is for low firing rate. Sorry, the high number of cells are for low firing rate. It means that we have a higher firing rate in MPTP monkeys compared to the normal situation, normal monkeys. And here we can see for the firing pattern, here the oscillations which are synchronized to the tremor, because the frequency of the oscillations of the burst is from 4 to 8 hertz. And we know that the oscillations for the tremor in the Parkinsonian situation, it's between 4 and 6. It means that we have many cells recorded in the subthalamic nucleus, which are really synchronized to the tremor in MPTP monkeys. And here it's a very good example that we can see here. Here is the repeated tremor realized by the MPTP monkey. Every peak is a tremor. You can see the oscillations of the tremor. And here are the peaks are the burst activity. And we can see that the bursts are really synchronized with the tremor. You can see every burst is synchronized with the tremor. It means that the subthalamic nucleus is involved in the pathology of pathophysiology of the tremor. And we can see here, if we calculate the frequency of the oscillations of STN neurons, we can see that it's around 5 hertz, which is really the frequency of the oscillations of the tremor. It means that we have a perfect synchronization between the tremor and the bursty activity in the subthalamic nucleus. And we have another population of neurons that are oscillating at a higher level of the subthalamic nucleus. Now, if we come back to this modeling of the motor circuits, I told you that we have in the normal situation this tonic activity, which can be recorded in the globus pallidus externus. We can also observe it in the subthalamic nucleus, and we can also observe it in the output structures of the basal ganglia, especially the globus pallidus internus. And this is really typical to the normal situation. It means in the normal situation in our brain, we have all the basal ganglia structures discharging with this kind of tonic activity. But when we have this degeneration of dopamine neurons, we will perturbate the organization of all the basal ganglia structures, and this disorganization will be also transmitted to the thalamus and to the cortex. And this is why the patients will develop akinesia and also rigidity and tremor. It's because of the loss of this dopamine, which cannot control or modulate the information coming from the cortex in the striatum. And this absence of modulation of dopamine inside the striatum will be the cause of the disorganization of the basal ganglia neuronal activity. And we can see it here that the tonic activity recorded in the normal situation will be converted to this bursty activity in the globus pallidus externus. We can have exactly the same perturbation in the subthalamic nucleus and also in the internal globus pallidus. It means that in the normal situation, we have this tonic activity, and it will switch to this bursty activity in all the structures of the basal ganglia when the dopamine is absent. And this is really the pathological signature of the basal ganglia in Parkinson's disease. And now we know that this bursty activity is typical to Parkinsonian situation. And we know now in animal models, as well as we had the chance to record the neuronal activity of the subthalamic nucleus in Parkinsonian patients, that we have in all these two models and in Parkinsonian patients, this bursty activity in the Parkinsonian state. We can see also this synchronization of STN neurons with the tremor, with the frequency of the oscillation at the frequency of the tremor, and we can see exactly the same in the STN, in the subthalamic nucleus of Parkinsonian patients. We can see this bursty activity. There is no tonic activity in the subthalamic nucleus. We have only these bursts, and the burst here, every burst is really synchronized with the tremor. And this configuration that we can see in Parkinsonian patient validate our animal models, because we are finding in our animal models exactly the same thing that we are observing in Parkinsonian patient. The bursty activity, which is here, we can see it in CISOHD animals and also in MPTP monkeys, and we can see this synchronization between the tremor and the bursty activity in MPTP monkeys. We can find it also in the patient. It means that we have the chance to have good models to study the pathophysiology of the disease, of Parkinson's disease. And this is a real chance, because for other pathologies, the animal models are not good. If we take an example of Alzheimer's disease, for example, there is no efficient animal model in this disease. This is why it's very difficult to find and propose some new approaches for the therapy. This is a chance that we have for Parkinson's disease. And I talked about the bursty and the spikes that we can record in the brain with a microelectrode for only one or two neurons near each other. This is, we can say, micro recording with single unit activity. It means that if we have the tip of electrode in contact of only one neuron, we can see this action potential, these spikes in the recordings. But we have another approach, which is named local field potential recording, which will be the recording of a population of neurons in the brain. And we will not use the microelectrodes, but we can use macroelectrodes. For example, the electrode of the stimulation that we are using in the patient, they can also serve to record local field potential. Local field potential is totally different from compared to the single unit microelectrode recording. It's just because here we are focusing on the neuronal activity of only one neuron, and here we are focusing on the neuronal activity of a population of neurons. And we can see that we will not see the action potentials here, but we are looking to this kind of waves, and we can calculate the frequency of the oscillations of these waves. It means that the action potential is a recording from a large number of neurons, a population of neurons, and it can reveal the presence of neuronal rhythms or synchronized oscillations in the structures of the brain. And it can be obtained by putting the electrode on the cortex, and also here we can have it inside the cortex or inside the brain. If you put a macro electrode, you can have this kind of local field potential oscillations, and we can compare them to the single unit activity of one cell. It means that local field potential is the recording of a population of neurons, and micro recording is only with a single unit neurons. And here we can see how we can record these different signals from local field potentials. We can put the electrode only on the skin. This is the EEG, electroencephalography, that we can use with the neurologist to explore, for example, the epileptic status in patients with epilepsy. We can also put it inside the brain on the cortex and inside the cortex also. And here we can have the different type of local field potential recordings. EEG, we can have ECOG because we have the electrode directly on the cortex, and we can have also the recordings inside the brain. And here you have action potentials with microelectrodes. Local field potential represents the oscillatory and synchronous activity of a population of neurons, and they aid in the understanding of brain dynamics in health and diseases, in health and in diseases also. Here, with local field potentials, we can have many different frequencies. And here is the repartition of the different frequencies of the oscillations. And we can have this delta band frequency around 0 to 3 hertz. We can have the theta from 4 to 7 hertz. Alpha is from 8 to 12. Beta is from 13 to 30, and we have the gamma from 31 to 200. Then we can have the high frequency without any classification. And what is important here, you should remember the beta oscillations, because all the bursty activity that we are observing in Parkinson's disease is also related to beta oscillations in Parkinson's disease. And this beta oscillation is really a biomarker of the neuronal pathology for Parkinson's disease, especially in the basal ganglia and especially in the subthalamic nucleus. You can remember this. You can see here the different frequencies. Here is the amplitude, the power of the oscillations of the local field potentials, and we have these different frequencies depending on the number of peaks here. Now, if you look to the beta oscillation in the subthalamic nucleus, the beta is a kind of stop of the movement. This is why we have this this red light. When you have the beta oscillation in the subthalamic nucleus, it means that we have a difficulty for the movement. Our movement is stopped. But however, if we look to the gamma which is very high, the gamma is a release of the movements. And when we can switch from Parkinson's disease with the beta oscillations, when we give the patients L-DOPA, for example, this beta oscillation will switch to the gamma oscillation for the release of the movements. And this is really very, very important. These two biomarkers are very important in the understanding the pathophysiology of the disease. And the beta oscillations can also be used as a biomarker in the brain in the pathology of Parkinson's disease. And now it's clear that the beta is to stop the movement, and the gamma is for the release of the movement. And here in rodent, we can also record this kind of local field potential. Here in the normal situation, we don't have the beta oscillation is at this level that we can find only in the Parkinsonian situation after the 6-hydroxydopamine injection in the substantia nigra or in the mid-forebrain bundle. And you can see that we have this peak around 20 hertz, which is typical to beta oscillations. And if you look here, we have the beta oscillations here from the local field potential in the subthalamic nucleus, and you can see that we have oscillations with the burst synchronized also to the beta oscillations. The bursty activity is really related and to the local field oscillations at the beta frequency. It means from here that the bursty activity and the beta oscillations are the two biomarkers of the disease. If we look now to the patient, here you have the patient without a treatment with L-DOPA, and we have here beta oscillations. And if you give to the patient L-DOPA with the blue here, you can see that we have a decrease in the amplitude with a disappearance, as you can see here, of the beta oscillations. Without L-DOPA, we have this peak at 20 hertz. It means that we have beta oscillations in the subthalamic nucleus. And by giving the L-DOPA to the patient, you will have this decrease in the beta oscillations. That is very clear here. And here also you can see the amplitude is very low with a disappearance of this beta oscillation. If we look now to the bursty activity and different parameters of the burst, we can see here without L-DOPA, we have a high mean burst duration. When you give to the patients L-DOPA, we have this decrease, significant decrease in the mean burst duration of STN neurons. We can see here also a decrease in the mean burst amplitude and also the burst probability. We have less burst with L-DOPA compared to the off L-DOPA situation. It means that the bursty activity, like the beta oscillations, will decrease with L-DOPA treatment. And this is important to know because then we can use these biomarkers, the burst and the local field potential beta oscillations, as biomarkers of the pathology. And in conclusion of this part, we can say now that the bursty activity of single cells with oscillations and synchronization, as well as the beta oscillations from local field potential at the frequency of 15 to 30 Hertz, beta oscillation, are the two biomarkers of the pathophysiology of Parkinson's disease. We can say that these are the pathological signature of the basal ganglia in the disease. Is it clear till here? Is it okay?
Yes, okay, everything's fine.
Yes, thank
Thank
you.
you.
If you have question, if you don't understand something, you can stop me. Okay, this is the first part with the pathological signature of the burst and the beta oscillations, which are very, very important now for the knowledge of the pathology. And now if we think about the therapeutical approach, as the subthalamic nucleus was demonstrated as an hyperactive structure of the basal ganglia, the first proposal was from the team of Malon DeLong with Hage Bergman, who said that we can avoid this hyperactivity in the subthalamic nucleus by doing the lesions of the subthalamic nucleus. And they injected ibotenic acid in the subthalamic nucleus in their MPTP monkeys, and they showed that the lesion of the subthalamic nucleus can improve motor symptoms like akinesia, rigidity, and tremor. But the problem is, and all the neurologists know, that the lesion in the region of the subthalamic nucleus in patients can have very bad consequences on the development of hemibalismus. And they observed in their monkeys this hemibalismus, the manifestation of abnormal involuntary movements in the monkeys with the lesion of the subthalamic nucleus. And you know that the lesion is an irreversible approach that cannot be proposed to the patients because of the development of this hemibalismus. All the monkeys were improved by the lesion of the subthalamic nucleus, but this improvement was also associated to the hemibalismus, which is not good for the patients. This is why the lesion was not proposed to Parkinsonian patients. And at that time, we proposed in my team to replace the lesion of the subthalamic nucleus by electrical stimulation using a high frequency stimulation. And when we say high frequency, it's higher than 100 hertz. And this high frequency stimulation was really efficient in improving the motor symptoms in the MPTP model. This is a model that we developed in the lab in Bordeaux. And we didn't inject MPTP intravenously or intramuscularly. We injected it in the internal carotid. And if you can observe this animal, you will see that he has only a unilateral Parkinsonism. The left side is totally normal, but the right side is really akinetic and rigid. It means that this monkey, with the injection in the intracarotid, the MPTP, it will cause, and the monkey will develop Parkinsonism in only one side. And it was really very good for us to use this model because he was able to eat and to move independently from a third person. In the case of generalized bilateral MPTP model, the problem is we can lose the monkeys because they are not moving, they cannot eat, and they have lot of problems. This is why we prefer to switch to this unilateral model. And in this unilateral model, it was the injection in the left side. This is why he has Parkinson in the right side. And we implanted an electrode in the left subthalamic nucleus. And the first thing that we observed is the effect of high frequency stimulation of the subthalamic nucleus on rigidity. If we look here to the EMG, we can record the activity of the muscle tone in the biceps of the monkey. We can see this low level of EMG recordings in the normal here, the left side of the biceps. If you look now to the right side, the rigid one, as the muscle is really contracted, this is why we have rigidity, you can see this increase in the amplitude of EMG of the biceps. And here you can see this rigidity expressed by the high level of the muscle tone EMG. When we start the stimulation, we are totally normalizing the EMG recordings. It means that we are improving rigidity with high frequency stimulation of the subthalamic nucleus. If we look now to the tremor, you can see here the recording of the tremor, the oscillations. And when we start the stimulation, we totally stop the tremor during all the stimulation period of time. And if you stop the stimulation, the tremor is coming back few seconds later. It means that here we have an improvement of rigidity, and here we can have an improvement of tremor in the MPTP monkeys. Here is another example of recordings of EMG, and we can see with repeated passive movements, and here you have the normal recording of EMG in the biceps and in the triceps in the normal situation, the control arm. And in the rigid arm, you can see this huge exaggerated muscle tone during the repeated passive movements. It's affecting especially the biceps, and here you can see that in the triceps it's not totally different from the normal situation, because here the animals are have only the biceps, which is very, very contracted with this rigidity. And now if we look to the STN high frequency stimulation, you can see that we are totally normalizing the muscle tone in the biceps, like that we can see here. It means that here it's a confirmation that STN high frequency stimulation is improving rigidity in the rigid arm of the MPTP monkeys. Now, if we look to akinesia, we trained on our monkeys to do flexions and extension of the movements of the elbow. And we can see here all the parameters of the movements. Here is the one set of the movements. And we can see that with the extension movement, we have a normal velocity of the movement, here the acceleration, and we record the AMG activity in the biceps, which is the agonist, and here the antagonist. And with MPTP, after the treatment with MPTP, we can see an increase in the time, or in the the time of the movements. The movements is prolonged because of the slowness of the movement. We can see this decrease in the velocity, in the speed of the movements. We can see this disorganization of the acceleration of the movement, and we can see also this exaggerated recordings of the AMG in the agonist muscle. And for the antagonist, it's also a little bit perturbated. If we look now to the stimulation with the high frequency of the STN, we can see a normalization of all the patterns of the movements. We can see this normalization of the time. The movement is not very slow. We can see this normalization of the velocity, which not different, significantly different compared to the normal situation. And compared to here, we can see this improvement. We have an improvement of the acceleration and a normalization also of the muscle tone, as you can see here. the EMG is totally normalized in the biceps and also in the triceps. It means here that we are really improving akinesia in our PTP monkeys. And this work was really very important to use to propose the transfer to Parkinsonian patients. Here, also the tremor, as I showed you before, we can stop also the tremor with the high frequency stimulation of the subthalamic nucleus. And after the result of this work, we proposed with Ali Louis Benabid and Pierre Pollack in Grenoble to start deep brain stimulation of the subthalamic nucleus in Parkinsonian patients. And we showed in many, many papers that STN high frequency stimulation can improve the cardinal motor symptoms of Parkinsonian patients. And this was really the beginning. In 1993, we did the first patients, and now you know that deep brain stimulation, it means that STN high frequency stimulation is used in all the world, in the all the centers of neurosurgery and neurology in all the world, with excellent results. And the efficacy of deep brain stimulation depends on three major parameters. All the neurologists and neurosurgeons know that. The first parameter that we have to respect is the patient selection. We cannot improve all Parkinsonian forms. We need to have good indications, and this is done, the selection is done by the neurologist, not the neurosurgeon. It's done really by the neurologist who is knowing very well the pathology. And we have now a lot of criteria of inclusion and exclusion. We cannot propose DBS to all Parkinsonian patients in the world. We have some forms where DBS is not working very well. This is why we need a very good selection of the patients by the neurologist. This is the first step. The second step, when we decide to operate the patients and implant the electrode, we need a precise targeting of the subthalamic nucleus. You see here, the subthalamic nucleus is a very deep structure in the brain, very small and very deep. It's not very easy to reach. This is why we need a good MRI control to see here the nucleus. And this is a very, very important step. Then, when we are targeting the subthalamic nucleus on MRI and we compare the location with the atlas of the brain atlas of the patient, of the humans, we can calculate the parameter, the stereotaxic parameters to put the electrodes inside the subthalamic nucleus. And to do that, we need a functional also approach, which is electrophysiology. Electrophysiology that we developed in animal models was used also to target the subthalamic nucleus, because we know that in the subthalamic nucleus in Parkinsonian patients, we will find this bursty activity. And this is really very important to do during surgery, to localize functionally the subthalamic nucleus. That can help us to know that we are really inside the nucleus. And at this level, when we have the burst, we can implant the chronic final electrodes. And this is done by a neurophysiologist. And after when we record the bursty activity during surgery, we can also do the stimulation test to be sure that we are improving the symptoms at the locations where we found the bursts. And this is also a very important step during surgery. And we need also to verify that with the parameters that are inducing the improvement of the symptoms, we don't have side effects. We need a margin, a very good window between the threshold of intensity of the stimulation inducing the improvements and the threshold of side effects. This is really very, very important. Why it's very important to find this large window? It's because of the evolution of the disease. With the time after surgery, the patient's symptoms will be aggravated with time, and we will need to increase the intensity of the stimulation. This is why we need this large window of the threshold inducing the positive effect and the thresholds inducing the side effect. And this is very important. Then neurologist after surgery, when the patient have his stimulator and the electrodes in the STN, he can program the stimulation parameters to have the most important and the beneficial effect with the good parameters of the stimulation. These are really the three important steps to have this efficacy of the brain stimulation. Now, I will talk especially about how we are targeting the subthalamic nucleus in patients during surgery. In Bordeaux, as in other centers, we have this robot who is putting the tip here to show us where we have to put the hole on the skull of the patients. And we have this O-arm, which is a scan that can be used during surgery to follow the descent of the electrodes. The neurosurgeon is working in this side. We have the neurologist who is here controlling the symptoms of the patients and controlling the state of the patient. And we have the neurophysiologist, I'm here, to do the micro recordings of the neuronal activity during the descent of the electrode. I have a command and I am going down very, very slowly by recording the single unit activity of the different structures of the brain. And when I see the bursty activity, this is, as I told you, the signature, pathological signature in Parkinson's disease. I will say that this electrode is inside the subthalamic nucleus. The role of the neurophysiologist is important during surgery to target the subthalamic nucleus functionally. And here are the images that we can obtain. In the beginning of the first surgeries, we were using 5 microelectrodes, as we can see here, to record the neuronal activity. You see that the subthalamic nucleus is very small here, and we use these 5 to surround all the region of the subthalamic nucleus and to see how many electrodes can enter the subthalamic nucleus. If you look to this example, you can see for this nucleus here, we have 3 electrodes going inside the subthalamic nucleus and 2 outside. It means that these 2 electrodes were not good because they will not give in us the neuronal bursty activity. And the bursty activity was recorded only with these 3. If you look here, you can see that we have only these 2, and the 3 others are outside the subthalamic nucleus. And we can follow this by the O-arm scan that we can see here, the central electrode going in the center here, surrounded by the 4 electrodes. And we can follow really during surgery this descent of the electrodes till we reach the subthalamic nucleus, which is located here. And this step is really very important in the control of the bursty activity during surgery in the patients. The patients are under local anesthesia. They are awake. They are not anesthetized generally. We are using only anesthesia on the skin because inside the brain, we are not feeling pain. And for the bone, no, we don't have pain. Pain is only for the skin. This is why we are just injecting anesthesia in the skin. And here is an example of the descent of the electrode. The advantage of the subthalamic nucleus that we have is that the subthalamic nucleus is a little bit isolated in this region. Above the subthalamic nucleus, we have the zona incerta, and in the zona incerta, there is no cell bodies. This is why we have a very low level of neuronal activity that we can see here for the 3 electrodes. In this patient, we didn't use 5 electrodes, we used only 3. Now, with experience, we rejected 2 electrodes. We are using only 2 to 3 electrodes. In this case, we have 3 electrodes. And you can see here in the zona incerta, it's a kind of silence. There is no bursty activity, no action potentials. And when the subthalamic nucleus, when the electrode will enter the subthalamic nucleus, you can see this increase in the background noise for 2 electrodes, the central and the anterior one. And in the third one, the posterior one, we don't have a neuronal activity. It means that only these two electrodes are entering the subthalamic nucleus. And if we continue our descent, you can see here this bursty activity in the two electrodes. It means that at this level, we are really in the subthalamic nucleus. And then we continue the descent. You can see that this electrode is still in the subthalamic nucleus because of this bursty activity, but the others are not in the subthalamic nucleus. It means that we left the subthalamic nucleus, but this electrode here, and this one is still inside. And if we continue the descent, we will see a decrease here. And this is a typical activity of the substantia nigra reticulata, which is just below the subthalamic nucleus. And I will show you another very good example of targeting the subthalamic nucleus. Here we have the zona incerta, which is really silent. When the electrodes are entering the subthalamic nucleus, you can see this bursty activity with oscillations. And it's very clear during the descent, when you have the subthalamic nucleus, you will see this bursty activity, which is very, very clear. And when we will go outside, deeper, outside the subthalamic nucleus, we have this decrease in the neuronal activity. Then we enter the substantia nigra reticulata. And this is why we can see this not bursty activity, but this activity of the substantia nigra reticulata. Another example here, we can see the entrance here of the subthalamic nucleus, and the subthalamic nucleus is continuously recorded till here. You can see this bursty activity, and when we are leaving the subthalamic nucleus, there is no bursty activity. And here we enter the substantia nigra reticulata. And from these recordings, this one and this one, we can see that this electrode is good because we can put it from here to here to cover a big part of the subthalamic nucleus. And here we can also, during surgery, record these oscillations with the tremor. This can show us that we are really in the subthalamic nucleus because of the synchronization between the bursty activity and the tremor of the patient. As the patient is awake, we can see that he can have this tremor that we can correlate with the bursty activity. It's very, very clear when you have a patient with tremor, and they will show you a video during surgery where you can hear the bursty activity correlated to the tremor. And now we know that the subthalamic nucleus is subdivided in three territories. We have this dorsal part, which is the sensory motor part of the subthalamic nucleus. We have the limbic part, which is the medial one, and the associative part of the subthalamic nucleus, which is the cognitive associative part. And as Parkinson's disease is first a motor pathology, we need to put the electrodes in the dorsal part of the STN, which is the sensory motor part, okay? And we can control this during surgery with electrophysiology. If we look to this recording, we can see that the neuron that we are recording is responding to the movement, the flexion movement of the wrist. We can see here this response, and it's very, very clear to hear these responses of the neurons. And we know that if we have this kind of responses, we are sure that we are in the sensory motor part of the nucleus. And this is important because it will add an advantage for the patients to be ameliorated very, very spectacularly. And this is important to do during surgery. We look to the spontaneous activity, but we look also to the responses of the neurons to the movements of the wrist or of the elbow. And here I will show you a video. I hope you will hear the sound. And in this video, I will show you during surgery the recordings of the neuronal activity of the subthalamic nucleus, and you will hear the oscillations synchronous to the tremor. And then we will stop the tremor. You will see that the bursty activity will disappear, the oscillations will disappear, and then we will hear also the responses to the movements. I start the video. These are really the burst activity oscillating with the tremor. You can hear the oscillation.
Synchronisé avec le tremblement. On va arrêter le tremblement.
If we stop the tremor,
Et la cellule continue à décharger, mais pas tellement en bouffée. Et regarde, on a une activation avec le poignet. Regarde. T'as vu? On voit bien qu'elle répond au poignet.
you can hear the responses that I told you before.
Sur les poignets. Tu vois? Elle est vraiment... en fait, ce qui déclenche la réponse cellulaire, c'est ça. Hein? Elle est activée par ça. Donc après, quand tu lâches la main et tu la laisses trembler, détendez-vous bien. Voilà.
Yeah, the bursty oscillations is really very, very clear. And you hear that we have these oscillations of the bursty activity with the tremor. And also when we stop the tremor, we have this oscillation disappearing. Then we can hear also the responses of the neurons to the movements of the wrist. It's really very good for us to know that we are exactly in the sensory motor part of the nucleus. Then when we are sure that we have these recordings, we can start the stimulation test. And this stimulation test will help us to determine the thresholds, as I told you, inducing positive and negative effects. The frequency used is all the time 130 Hertz. In the majority of centers, we are using 130 Hertz because it's really an optimal frequency to use in with the brain stimulation. The pulse width, are the larger of the pulses. It is of 60 microseconds, and the amplitude, which is the voltage or the intensity, can be variable for a patient or another one, and it's from 0 to 10 milliamps. That's the intensity that we are really testing. And the result of this stimulation test will allow the final decision of the best electrodes. Because in the majority of cases, we don't have only one electrode entering the subthalamic nucleus. We can have 2 to 3 electrodes entering the subthalamic nucleus. And differentiation, we can differentiate with them if we have the bursty activity in these 3 electrodes. The stimulation test can discriminate between them to select the best one, inducing positive effects with low intensity and side effects with high intensity. And this will be a very good window from the 2 threshold for the future of DBS in patients. And this step is really very, very important too. The stimulation test is important. And here we have a patient. During surgery, we tested the high frequency stimulation, and that we can see is we will see that when we start the stimulation, we will stop the tremor, and when we will stop the tremor, we will stop the stimulation, the tremor will come back. The patient is tremoring. Stop. When we start the stimulation, we can see clearly that we are stopping the tremor. Stop. We stimulate, we stop the tremor. It's very clear. We can see it also here. We stop the stimulation, the patient starts to tremor in the hand and also in the leg. Stop. We stop immediately the tremor with the stimulation. And this is really very clear. When we are really the electrode, they are in the subthalamic nucleus, you will all the time see this improvement of the tremor. And we can also test rigidity by doing passive movement of the wrist and the elbow. And we can also ask the patient to do some movements like this to improve, to see if we are improving akinesia. But when you are a very efficient effect on the tremor, as we can see on these videos, you are sure that you will have a beneficial effect for rigidity and also akinesia. And here we did a study with Pierre Polak to see what happened when we are stimulating inside the subthalamic nucleus and what happened when we are stimulating outside the subthalamic nucleus. If we can see here, the subthalamic nucleus is located here, and we can see that we are improving rigidity, tremor, akinesia, and sometimes we can induce transient dyskinesia when we are stimulating inside the subthalamic nucleus. If we are outside, if the electrodes are outside the subthalamic nucleus, we can see only side effects. Here, we can see dizziness by stimulating in this region. If we are stimulating in the internal capsule, we can have these contractions of the muscles, tetanic motor contraction. We can have dysarthria, difficulty to talk and to speech, gas deviation. And if we are ventrally of the subthalamic nucleus, we can have this eye deviation, paresthesias, and autonomic symptoms. Here it's a coronal plane, and here the sagittal plane, we can see exactly the same side effects. It means that by stimulating the subthalamic nucleus, we will improve the symptoms, but by stimulating outside the subthalamic nucleus, we can have only side effect. This is why it's very, very important to do electrophysiology during surgery to be sure that we are recording this bursty activity, which is really the pathological signature of the subthalamic nucleus in Parkinson's disease. We need also to do the stimulation test to be sure that we have a very good window between the threshold inducing positive effect and the threshold inducing side effect, because we will need in the future to increase the intensity of the stimulation and avoid the induction of side effect. And all these parameters are very important for the efficacy of deep brain stimulation in the patients. And at the end, when we decide that this is the best electrode that we have to use chronically, we implant the final electrodes bilaterally in the subthalamic nucleus. Then we implant the pacemaker and we connect the pacemaker to the electrodes. And we can do this post-operation MRI control to see if the electrodes are really inside the subthalamic nucleus, which is here. And you can see that it's very, very deep. This is why this approach is named deep brain stimulation. Okay, here I will show you a patient with severe tremor, akinesia, and rigidity. It's a very advanced stage of Parkinson's disease with this patient. And here you can see the severity of his tremor. The patient is not taking L-Dopa and he is not stimulated here without stimulation. We are asking him to do quick movements. You can see the difficulty that he has to move. And he is really very, very troubled by the tremor. After surgery, we can see that he is totally improved without any tremor. He can move his legs normally. No tremor, nothing. Okay. Now we will ask him to do the movement as before, and you can see that he is doing normal movement without any problem. And it's bilateral effect because he has the two electrodes. We come back before stimulation, and you can see that he has difficulty to move his hand. He is really akinetic, severe akinesia. You can look also to his face. His face is very rigid.
D'accord. Vous allez maintenant avec la main droite encore faire des mouvements de pince comme ceci en plomb.
Now we ask him to do some precise movements, and you see the difficulty that he has to move with precisions. After surgery with the stimulation, you can see that he becomes totally normal. He's moving his hands normally. The precision now of the movements, you can see that the movements are really very, very precise.
Okay.
Now we ask him to stand up. He has a lot of difficulties to stand up, and he tried to block his tremor. Now he will turn in small steps. He cannot turn in one time because of the pathology. We will ask him now to do exactly the same things with the stimulation. Yeah, he will turn in one time. Okay. Then we will ask him to walk in the hospital. And this is typical to Parkinsonian patients with these very small steps of walking. And we will see with the stimulation, he works totally normally. And if you meet this patient in the street, you cannot know that he has DBS or Parkinson's disease. It means that it's really, when we are targeting the subthalamic nucleus with precision, we are sure that we will have this beneficial effect. Here, another suffering young patient, he has a genetic form of Parkinson's disease. And you can see the difficulty that he has also with the pathology, postural problems, and he has totally, really akinetogenic and tremor patients. This surgery was done in Marrakesh. I introduced deep brain stimulation in Morocco since 2007. Now we have 6 centers there who are doing DBS. And you can see the severity of his pathology here. You see that the patient is really suffering. And after surgery, I visited him 3 months after surgery, and you can see that he is totally normal. He is walking normally, and here we will see also that he is moving totally normally with normal movements. He has no problem. He has really improved. And this, I wanted to show you also another video for juvenile Parkinson's disease with the genetic form that for a young lady in the United States.
So I just got my DBS programmed. Yay.
She has the
And so
electrode
I'm
and she is on
so
stimulation now.
I'll show you what that looks like. So I've got arms that can stay still instead of shaking, hands that can do this. I put my arms up, around. I can lift my leg up.
Yeah, it's totally normal.
And
She is normal.
balance, no problem. So I'm going to turn it off and see what happens and to show you what it looks like. So this is my DBS remote. That's my dog. That's my DBS remote. And so it's synchronized to my battery, so you can see that it is on and okay. It means that my battery's charged and that my DBS is on. If I push this white button, it will turn it off. So
yeah, now she will turn off the stimulator and you will see the change.
Don't keep watching. I'm off.
Yeah.
Okay.
By switching off the stimulation, she is totally Parkinsonian now. She cannot move. She has this dystonia.
My voice, my throat muscles are having to work a little extra hard. I can't lift my leg up more than that. So I'm gonna try to pack on.
Yeah, she will switch on now.
I can't smile anymore. No, it's just my facial muscles failing. So here we go.
Yeah,
Oof.
it's an immediate effect.
It's literally as simple as that. You can see it's back on now. That's DBS.
That's DBS, yeah. By showing you these 3 videos, we can see that DBS can work in the different form of Parkinson's disease, juvenile form, genetic forms, and also for advanced stage of the disease. And why we have these beneficial effects, which are very clear, it's because of the good selection of the patients, the good targeting the of the subthalamic nucleus, and the good programming of the stimulation after surgeries. And this is why we say that DBS is a teamwork. We need neurophysiologists, we need neurologists, and also we need neurophysiologists, neurosurgeon. And now we need also psychiatrists to be sure that in these patients before surgery, they are not depressive, they don't have a resistant form of depression. This depression is very important to look on because in severe forms of depression in Parkinsonian patients, we will aggravate this depression with deep brain stimulation. We need to control depression before proposing the stimulation of Parkinsonian patients with depression. And this is really very, very important to collaborate with the psychiatrist and to have this evaluation of all the psychiatric pathologies in Parkinsonian patients. And in conclusion of this part, also, we can say that the efficacy of STND brain stimulation is shown in the majority of PD patients when the selection is well done with a good targeting. However, in some cases that I showed you is really the perfect patients that we have. But in some cases, even if the selection of the patients and targeting of the STN is well done, the efficacy can be limited. And be, perhaps this is due to the interaction with the other systems which are not normal in the brain of Parkinsonian patients. And we can think about the monoaminergic systems, for example, which can be involved in the absence of effectiveness of the brain stimulation. And we did a work in rodents. This is why I told you in the beginning in my title, from bench to bedside, and we switched from animal models to patients with the brain stimulation. Then we came back to the animal models now to try to understand why in some cases DBS is not working very well. And I will show you a study that we did in a rat model of Parkinson's disease by targeting the monoaminergic systems. We know that dopamine is the most important neurotransmitter for Parkinson's disease. The most important thing is the degeneration of dopamine neurons that can cause the manifestation of the motor symptoms. But we know that also in some patients and in some forms of Parkinson's disease, we have also the degeneration of noradrenergic neurons or the serotoninergic neurons, or the three systems can be affected. Not in all the patients, but in some cases, we can find the degeneration of these three systems, monoaminergic systems. And that we did in rodents is to try to understand what happened by lesioning or by doing combined lesions of these systems. Here we can see this is a publication that we did, I think, in 2015. And we did is to develop combined lesions in our rats. Here we can see the sham animals without a lesion. We injected only saline in the midbrain forebrain bundle. Here we can have the 6-hydroxydopamine injection to induce dopamine depletion. In this group, we did a combination of the lesion of dopaminergic and also noradrenergic neurons. In this group, we did a combination of lesions of the dopaminergic neurons and the serotoninergic neurons. And here we have a combination of the three depletions. And that we can conclude from this histogram is that dopamine is inducing a decrease in locomotor activity, which can correspond to akinesia in our rodents. The dopamine depletion is inducing a decrease in locomotor activity. But these locomotor deficits is not aggravated by the combination of the depletion of the other systems. Okay, and if we look now to the effect of deep brain stimulation in the four groups of animals, here the group with only dopamine depletion, we can see that DBS is improving significantly the locomotor deficits. We are really improving akinesia in our rodents here with 6-hydroxydopamine. DBS is effective, is efficient, and induce a beneficial effect. If we look to the other groups with combination of depletions here, dopamine, serotonin, dopamine, and noradrenaline, and the three systems, we can see that we are improving very, very slightly the locomotor deficits in the three groups. We have a beneficial effect, but which is very, very limited, which is not excellent. And we think that akinesia, if it is not improved sufficiently in Parkinsonian patients with good targeting and implantation of the electrode, it can be due to the depletion of the other monoaminergic systems. This is the conclusion from this paper. And we look also to anxiety, and we can see exactly the same results. DBS is improving anxiety when the rodents have only dopamine depletion. And if they have additional lesions of the other monoaminergic systems, we are losing the beneficial effect on anxiety. It means that in patients, when we are not improving anxiety with DBS, perhaps these patients have combined depletions of the other monoaminergic systems. This work was done on rodents in the rat model. We are not sure that it is working in the same way in patients, but this is just a kind of hypothesis that we can now advance to explain why in some cases we don't have a perfect beneficial effect with DBS. And we have a collaboration now with a team doing PET scan in Toulouse to see if in some patients, if we have this kind of problems in Parkinsonian patients who are not responding very, very goodly to DBS of the STN. In conclusion of this part, we can say that additional depletion of noradrenaline or serotonin to dopamine depletion are not aggravating the motor and non-motor symptoms, as I showed you, but they can interfere with the therapeutic efficacy of STN deep brain stimulation. Now, the last part of my course will focus on the mechanism of action of deep brain stimulation. When you think about electrical stimulation, you can think about an excitatory effect, but we are not inducing the result of DBS cannot correspond to the excitatory effect because we are mimicking the effect of a lesion. It means that deep brain stimulation cannot have an excitatory effect, but an inhibitory effect. And I will demonstrate to you that we are inhibiting the neuronal activity by the high frequency stimulator of the subthalamic nucleus. We are not increasing the neuronal bursty activity. We are really depressing this bursty activity. And the idea came from many, many studies showing that high frequency stimulation can mimic the clinical effect of a lesion. The first demonstration is DBS of the ventral intermediate nucleus of the thalamus is inducing exactly the same effect like the thalamotomy, like the lesion. If we look to the subthalamic nucleus, Hage Bergman and Aziz Tipu showed that the lesion can improve the symptoms in the MPTP monkeys, and we are reproducing also this effect with high frequency stimulation of the subthalamic nucleus. It means that STN high frequency stimulation is mimicking the effect of the lesion. And here for the internal globus pallidus, Marwan Harris and Leighton indeed the several lesions of the globus pallidus internus, and this lesion effect was also mimicked by high frequency stimulation done by Lozano in Toronto. From this, we can just have the hypothesis that high frequency stimulation mimics the clinical effect of a lesion because we are inhibiting, not exciting the subthalamic nucleus. or the other structures. And now we did several works in animal models and also in the patients by stimulating the STN and try to record the neuronal activity, the neuronal responses in different structures of the basal ganglia and also the thalamus and the cortex. And the first study that we did was done by Mr. Tai, Professor Tai, who is a professor of neurology in the University of Taipei. My greetings to him. And he was my postdoc in Grenoble, and we published in Grenoble. Then he followed me to Bordeaux in 2001, and we published in 2003 this work that he did in 6-hydroxydopamine rat model. That he did is he stimulated the subthalamic nucleus and he recorded the neuronal responses in the subthalamic nucleus. And that we can see is in the majority of STN neurons that he recorded, we have an inhibitory effect. A total effect inhibition in 15% and a decrease, dramatic decrease in the bursty activity and in the firing rate in 72%. It means that in the majority of the neurons that he recorded, 87% were inhibited, not excited. We have only 4% of the cells who were excited by STN high frequency stimulation and 9% without any effect. This is really by recording near to the stimulating electrode with using high frequency stimulation. This is an inhibitory effect, clearly inhibiting the subthalamic nucleus. In the monkeys, we did exactly the same with the Meissner, Vasilios Meissner. In my team also, we did this work, we published it in 2005, and we can see here that before the stimulation, we have this high level of firing rate. When we start the stimulation, you can see this significant decrease in the firing rate. And when we stop the stimulation, the firing rate becomes like before high frequency stimulation. It means that we are decreasing the firing rate, not increasing. It means that we are inhibiting the subthalamic nucleus with high frequency stimulation of the subthalamic nucleus. And if we look now to the pattern of discharge, the autocorrelogram will show us the bursty activity and the cross-correlogram, the oscillations and the synchronizations. And that we can see here in normal situation, we have only few cells with the bursty activity. However, by inducing Parkinsonism with MPTP, we have this increase, a huge increase in the number of bursty neurons in the monkeys, in the subthalamic nucleus of the monkeys. And here we can see that these bursts are oscillating with synchronizations that we don't have in the normal situation. Cells in the normal situation are not oscillating like MPTP monkeys and not synchronized, as you can see here, the increase in MPTP compared to normal. Now, if we look, this is the representation of this in MPTP before surgery. With the stimulation, we can see that during high frequency stimulation, we are totally normalizing the pattern of the burst, and there is also no oscillation, no synchronization. When we stop the stimulation, the bursty activity and also the oscillation and synchronization is coming back later. It means that we are decreasing the number of action potentials, the frequency is decreased. It means that we have an inhibitory effect, and we are also normalizing the bursty activity. We have less burst than the normal, than with high frequency stimulation, than the MPTP situation. If we look now to what happened in the patient during surgery, Walter and Filali did several works in patients by stimulating the subthalamic nucleus. Here are the artifacts of the stimulation. Here are the bursty activity before and after. If they remove these artifacts, you can see that we have a very clear decrease of the firing rate and the bursts in the STN neurons during the high frequency stimulation, which is here. Sorry. And we can see it clearly here also. And if we look to this curve, we can see that we have a significant decrease of the firing rate during STN high-frequency stimulation. It means that in rodents, as well as in non-human primates and in human patients, STN high-frequency stimulation will inhibit the neuronal activity, not activate the neuronal activity. If we look now to what happened in the efferent structure of the STN, here is the substantia nigra reticulata. We stimulate, this was also done by Professor Tai. We can see that by stimulating the STN and recording the substantia nigra reticulata neurons, we can see exactly the same result that I showed you for the STN. The majority of the neurons recorded in the substantia nigra reticulata are inhibited totally or partially with high frequency stimulation. Here we start the stimulation, here we stop the stimulation. And during this period of time with the stimulation, we are decreasing or totally inhibiting the firing activity of the substantia nigra reticulata. And in 16%, we don't have an effect. But in the majority of neurons that we recorded, we have this inhibitory effect. If we look now to the thalamus, which is here, you know that the thalamus is influenced by the GABAergic projection, inhibiting the thalamus, and this projection is coming from the output structure of the basal ganglia. And you know that during in the Parkinsonian situation, we have an hyperactivity of the GABAergic neurons inhibiting the thalamus. And if we inhibit the neurons in STN, that can induce an inhibition in the substantia nigra reticulata and the globus pallidus externus, we will release the neuronal activity in the thalamus. This is why we see this increase in the neuronal activity of the thalamus with high frequency stimulation of the subthalamic nucleus. And there is an interesting work done in Rome, in Italy by Stefani, and they did a microdialysis approach in Parkinsonian patients during surgery. They put a stimulating electrode here in the STN, and they put a probe of microdialysis in the ventral anterior part of the thalamus. And that they observed is here the level of GABA recorded by microdialysis during surgery before DBS, and during the stimulation, they observed a decrease of GABA in the thalamus. And this is a decrease of GABA concentration in the thalamus will release the neuronal activity. This is why in electrophysiology, we will see this increase of the neuronal activity. It's just because we are decreasing the inhibitory effect of GABA as they showed here, a decrease in the level of GABA in the thalamus. And this is very important. This work was very, very important to explain why we are observing this, this increase of the neuronal activity in the thalamus with deep brain stimulation. Now, if we look to the cortex, I told you that we have a marker of the pathology, which is with local field potentials, which is the beta oscillations. You remember that the frequency of beta oscillations is from 30 into 30. We can see here in the pathological situation, this increase of the beta oscillations. And when we are stimulating the subthalamic nucleus with high frequency, these beta oscillations here will disappear. And we can see it here statically. Here is before DBS, and here with DBS, we are decreasing the area of beta band oscillations. If we look now to another study for the cortex, the motor cortex, the M1 cortex in the rodents, I told you before that in intact animals, we have this tonic activity. With 6-hydroxydopamine injection and the depletion of dopamine, we have this tonic activity replaced by the bursty activity, even in the motor cortex. And we can see that with 125 hertz, ST and DBS, we are improving the neuronal activity in the cortex. A disappearance of the bursty activity that we can observe here, and which is this activity is totally compared to the intact animals with the normal neuronal activity in the cortex. And if they use 10 hertz, which is very low frequency of the stimulation, they are not improving the bursts. The bursts are still there. It means that we need a high frequency stimulation higher than 100 hertz to obtain this beneficial effect on the burst. Sorry. This is another study where they showed also the effect of high frequency stimulation by recording the pyramidal neurons. And that they showed is that high frequency stimulation is inducing a decrease of the neuronal activity in the majority of neurons that they recorded. And here only a few neurons showed this increase of the neuronal activity. And what is interesting in this work is that they did recordings for the three populations of the cortical neurons in the M1, the motor cortex. They did the recordings of pyramidal cells, but they did also recording in the parvalbumin interneurons and the somatostatin interneurons. And we know that pyramidal cells are influenced by these two populations of interneurons. And they explain that the inhibitory effects that they are observing in the pyramidal cells of the cortex are due to the activation of the somatostatin interneurons by DBS. And this was observed in the majority of somatostatin interneurons. The stimulation of the STM is inducing the increase in somatostatin interneurons who are normally inhibiting the pyramidal neurons. This is why we can see here this inhibition at this level. And in conclusion of my course, we can say that high-frequency stimulation of the subthalamic nucleus is improving the motor symptoms in animal models and also in Parkinsonian patients by a direct inhibition of STN neurons. And this can be also due to the activation of GABAergic fibers coming from the globus pallidus externus to the subthalamic nucleus. And this inhibitory effect of STN neurons is inducing a decrease of the neuronal activity in the output structure of the basal ganglia, which are increasing the neuronal activity in the thalamus. And this increase in the thalamus will influence a reduction of cortical oscillations, as I showed you that the bursty activity oscillating in the cortex will disappear with high frequency stimulation of the subthalamic nucleus. And all these phenomena are involved in the improvement of the motor symptoms. And to finish, I just want to acknowledge the people with whom I worked during my PhD, Bernard Biolac and Christian Gross. The work was done for my PhD thesis in Bordeaux, in the University of Bordeaux on the monkeys. Then I left Bordeaux to go to the team of Benabid, where I did my postdoc with Benabid and Pierre Polac. And we did the first cases of Parkinson's disease with DBS. Then here, my actual team working on animals and also on human patients. And then thank you very much for your attention.
Thank you very much, Professor Menajot. Any question from the floor? From the audience?
I'm ready
Any
to
question?
answer your question now. Yeah.
May I ask the first question? Professor Menajot, you are mentioned in your study, you found that if the animal or maybe patients has additional motor arming system involvement in addition to the dopamine system, those patients might or the animal may not be have a good response to deep brain stimulation. So in clinical setting, how is there any other way to we can find out those kind maybe not potentially not a good candidate for the PD surgery?
Yeah, this is an excellent question because the work that we did was on rodent. This is what you said, and we show clearly that we have this negative interaction of the depletion of the other systems, noradrenergic and serotonergic system. The difficulty now is to explore this in human patients. We have no approach now to say that in these patients we have the depletions of the other systems. This is why we started this work with another team in Toulouse to do some PET scan and to try to see if we can detect these depletions or not in Parkinsonian patients without DBS, and also with DBS if the effect is not really very clear. This work is in progress. We have a financial support for it, but we don't have now the result, not yet. I hope we will have them in the near future. And I think it can help to answer this question and to avoid to operate patients with these different combined depletions, because we will know that the results will be not perfect. And in all the centers, we have in the majority of cases beneficial, very good beneficial effect, but in some patients, in all the centers, we have some patients with moderate to low level of improvement of the symptoms. Yeah, I think it will help. Thank you.
Okay, thank you. Let me see any. The second question is, just last month, our National Health Insurance Bureau approved to reimburse the deep brain stimulation treatment in dystonia patients. So that is a very good news for those patients because some of them struggle with the dystonia. Can you give us some recommendation for maybe the predictor for those patients may receive the deep brain stimulation treatment? I think the best and also the best best stimulation site. I think many papers mention about the GPI, but some other places maybe. Yeah, please. Thank you.
Dystonia, really DBS in dystonia is working very well, but we have to pay attention to different parameters. The first one is the selection of the patients. We need the primary, not secondary, forms of dystonia. It works only on primary forms, especially the genetic forms of dystonia. It works really very well in young people and also in adults. And the target is GPI, especially the posterolateral part of the globus pallidus internus. It works really very good. And recently there is some papers showing also that STN stimulation can also improve certain form of dystonia. But I don't have the feeling that the STN stimulation is better than GPI. I think GPI is more effective because we have a large experience now with GPI stimulation especially in the primary dystonia forms. But what is sure, it doesn't work in the secondary forms of dystonia. Yeah, that's sure.
Yeah, our national health insurance also reimburse the tardive dystonia. What's your opinion about that?
What kind of dystonia you said?
Tardive.
Yeah.
Tardive.
I don't have experience with that. I don't know really exactly what happened with these forms. Yeah.
Okay, thank you.
Yeah,
We
thank
have
you.
a question from the audience. Luisa Martinez, so you can turn on your microphone.
Hi, good afternoon.
Please.
Nice to meet you, Professor. Nice to see you, Professor.
Thank you.
It's an honor for me to listen your lecture. I have a question. You mentioned that the efficacy of deep brain stimulation depends on good patient selection. So I want to know what traits may disqualify a patient from participating in the deep brain stimulation.
Yeah. The good selection is very important, and only neurologists can do it. And from the inclusive parameters for the patients is idiopathic Parkinson's disease, not atypical Parkinsonian syndrome. It doesn't work in the Parkinsonian syndrome. It works only in idiopathic forms. No problem with genetic form, juvenile, adult, genetic form. All the genetic forms respond very, very goodly to the deep brain stimulation. The second thing is we need that the patient has a minimum of 3 to 4 years of the disease to be sure that the evolution of the disease is for Parkinson's disease, idiopathic Parkinson's disease, not atypical forms like SLA or another form, MSA, etc. Because we know that DBS is working only in idiopathic forms of Parkinson's disease, not for the Parkinsonian syndrome. It will not work because there is not only dopamine depletion, there's many lesions outside, especially in the striatum, for example, or in other places of the brain. DBS is working like L-DOPA. If your patient is responding very goodly, even during a short time, to L-DOPA, you can know that he will have the same beneficial effect with DBS. The difference is the effect is stable with time. Now we have 2 3 years experience with DBS, and it's still working for patients who are still in life. This is the difference with L-DOPA. With DBS, we are mimicking the beneficial effect, the best beneficial effect of L-DOPA, which is stable with time. This is the advantages. One of the major side effects that we can avoid is depression. If your Parkinsonian patient has severe depression that you cannot control, it's a very bad candidate to DBS because we had many cases that we operated in the beginning and with severe depression, and we aggravated their resistant depression to medication. We also had some cases of suicide. This is why we have to avoid to operate Parkinsonian patients with severe resistant depression to be sure that we will avoid this kind of suicide or an aggravation of depression. These are the major things to have to take into account during the selection of patients.
Thank you.
Thank you.
How about the cognitive issue? I
Yeah.
think that for many years,
Yeah.
some groups think that it's not a problem, but some
Yeah.
groups think it's a problem.
Some slight, I can say, cognitive problems can be improved, but with the evolution of the disease, especially with the problem of dementia, several patients will have the evolution of their dementia. They are perfectly improved for their motor symptoms, but we are not improving the cognitive problems and dementia. These severe cognitive problems are excluding criteria for the patients. Yeah, because we know that it will not work on these forms. Yeah.
I remember in the last Congress, there's a group doing the deep brain stimulation on the basal nucleus of males for treating the dementia.
Yeah.
Is it
Yeah.
effective?
Not really. Lozano did a lot of DBS for Alzheimer's disease and certain form of dementia, but the study was financial. It was supported by Boston Scientific, and they decided last year to stop all the clinical studies because
Oh,
the results
okay.
are not good. No.
Uh,
It's very difficult to operate patients with dementia because there is an atrophy, severe atrophy of the brain. In the
mm,
beginning, it can work. When dementia starts, this is that what Lozano showed. In the
uh,
beginning of the disease, still you have cells in the hippocampus and you have this foral connections, etc. The stimulation will work perfectly. But the problem that we cannot stop the degeneration. We are applying only on the symptoms. We are improving the symptoms. Like for Parkinson's disease, we are not protecting dopaminergic neurons. And it's exactly the same for Alzheimer's and also dementia. We are not preventing the degeneration of the neurons. It means that the neurons will continue their degeneration. And this is why in the beginning we can have good effect, but with the evolution of the disease, we will lose all this beneficial effect. This is why they decided to stop. I think nobody now is proposing DBS for dementia and for Alzheimer's disease. Yeah.
Thank you.
Thank you.
And we can achieve. Okay. Any question from the audience? Professor Jianhe Lin or Professor Sumei Chen?
Yes, thank you. Thank you, Professor. That's a very wonderful lecture. I'm Dr. Lin. I'm a neurosurgeon. And
Okay.
I'm another expert for, deep brain stimulation. I appreciate your lecture. I enjoy
you.
that. Thank you.
Thank you very much.
Okay, because of the time, we have to stop here. Thanks again, Professor Benazzo can give us a very comprehensive review of the deep brain stimulation, especially treating in Parkinson's disease. I think this therapy brings a very, very good hope in some of those patients, but not all the patients suitable for them. So that's why the topic is from bench to clinic, then back to the bench. So they still have many things we need to solve. Let's work together for the future.
Yeah, sure.
Thank you very much. Thank you.
Thank
Thank
you
you.
very
Can
much.
I'm
Yeah.
sorry.
Oh, sorry.
It just come to my mind that I have a question, but it's a very general question. That you in your study, your wonderful study in your animal or both in a human study, you say that high frequency stimulation will give a inhibition signal, right?
It's
And
good. Sorry.
high frequency stimulation, yeah, it can give the inhibition signal to the
Yeah.
neuron. So you mean that's for a single neuron or just a fear of the neurons?
It's when you are recording single neurons, you will see this decrease. And with local field potentials, we can also suppress beta oscillations for populations of neurons, for sure. Yeah.
Okay.
It's really a
And
very clear inhibition
yes,
of beta oscillations and also the hyperactivity of the spikes. Yeah.
sure, your data show that's very clear. But I just in the I would say ion channel cell membranes label in terms of a percent. Yeah, how can this happen?
Yeah, we know that it can be due to the depolarization block, you know.
Okay.
When you start the stimulation, you can have this immediate increase of the neuronal activity, but the neurons cannot follow this high level of excitation, and he will stop totally its activity. This is a kind of a block of depolarization. Yeah.
Okay. Thank
Yeah,
you. Clear.
this is one of the explanation, and we can say also another explanation. This is why we said with the electrical stimulation, we are not selecting the stimulation for only the cell bodies. We can also stimulate and activate the actions, the axons coming from the globus pallidus to the subthalamic nucleus, and it will release GABA inside the subthalamic nucleus that can reinforce this inhibitory effect also.
So interesting.
Yeah, these are the two mechanisms of the inhibitory
Yes.
effect. Yeah.
Yeah.
And next year, if you are interested by another course like this, we can add 30 minutes to my course, and I can add other pathologies than Parkinson's disease. I can
Great.
talk about OCD and also dystonia. I can prepare additional slides for these two pathologies because I see that
Very welcome.
we had the
Yes, thank you.
psychiatrists with us, which is who
Yes.
can be interested in psychiatric diseases, and you for dystonia. I can add these pathologies. Yeah.
Thank you.
So
Thank you.
welcome.
Thank you very
That's
much.
wonderful.
Thank you very much.
Thank you very
Thank
much for
you.
the invitation. It's always a pleasure to discuss with you and to give this course to your students. Thank you to all of you.
Thank
It
you.
was really a pleasure to exchange with you. Thank you.
Thank you.
Thank you. Thank
Bye.
you, Dr.
Bye
Yes.
bye.
Bye bye.
Thank you very
Bye.
much.
Bye
Bye
bye.
bye.